Today I'd like to welcome Dr. Constantinos Zambirinis to the podcast. Constantinos had a circuitous route to our Brown surgery training program. He attended medical school at the University of Athens in Greece. He then went on to complete his master's in cancer research at King's College in London. He then made his way to the US, where he worked as a postdoc at NYU for 2.5 years studying pancreatic cancer. He then started his general surgery residency at Harlem Hospital, where he also found time to study pancreatic cancer metastasis and hepatic pre-metastatic pancreatic metastasis over at Memorial Sloan Kettering. We were lucky enough to land Constantinos in his third year to complete his general surgery residency with us, and he will now be going on to Rutgers to complete his surgical oncology fellowship next year. All right, so I'd like to welcome Dr. Constantinos Zambirinis to the podcast today.
Hello, Ken. I'm excited to be here talking about HIPEC.
We've been doing HIPECs at our institution for some years, here with Dr. Miner, obviously, and I think it's still an operation and a technique that still not confuses some residents, but I don't think a lot of our residents who, when they start rotating on the surgical oncology service, have a great understanding of the role for HIPEC, how it's done, and some of the postoperative care around those patients. So, the first question that I would have is what exactly is HIPEC?
Yeah, so first of all, let me disclose that I'm not an expert in HIPEC, but I hope to become one day. Briefly, HIPEC stands for hyperthermic intraperitoneal chemotherapy, and essentially refers to the administration of chemotherapy in the peritoneal cavity, either open or laparoscopically. But when we talk about HIPEC, we usually talk about combining it with cytoreduction, which means that we're trying to take away macroscopic disease from the abdominal cavity and allow the chemotherapy to dwell in the abdominal cavity so it can target the residual microscopic disease. This process does not address any extraperitoneal disease, so this has to be factored in when selecting the patients. And actually, this is one of the biggest challenges nowadays, and that's why we've had several recent trials that have seemingly negative results. I think a big part of it is attributed to the fact that we are not that good in engaging disease biology, and I think that's where the future will have exciting stuff to follow.
How exactly did HIPEC evolve, and what are some of the rationales behind its therapy?
Yeah, so I think that's a key question to understand where we are standing today and where we are headed in the future. So it actually dates back almost a century ago. First person to start aggressive debulking was Joe Meigs with the eponymous syndrome, who was working on ovarian cancer and demonstrated that if you aggressively debulk the peritoneal surface, you improve patients' survival. This was expanded to the disease entity of pseudomyxoma peritonei in the 60s and 70s when chemotherapeutic agents began to improve at the same time. And in the late 70s, Robert Dendrick performed the first pharmacokinetic studies on IP, meaning intraperitoneal chemotherapy administration, and he noted that IP chemotherapeutics can achieve a much higher concentration on the peritoneal surfaces than if they were administered systemically, with a much less serious side effect profile. So it was very beneficial in that sense because it could kind of target the tumor burden regionally, and that was potentially exploitable biochemical advantage for the treatment of patients with microscopic peritoneal seeding, either to treat what's there or to prevent future metastases from evolving. But Dendrick didn't have an apparatus to administer the chemotherapy. So around the same time, Fortner from Memorial Sloan Kettering and his team worked on developing the first real HIPEC apparatus and demonstrated its efficacy in rats. So this wasn't just one person developing it, really. It was multiple people who were smart enough and enthusiastic about it and were forward thinkers who were developing the technology. At the same time, John Spratt demonstrated the benefit of heated intraperitoneal perfusion in dogs. He developed a clinical delivery system that he called TIF's Thermal Infusion Filtration System. And Palta and colleagues developed an IP therapy filtration system. So they both kind of simultaneously paved the way for HIPEC.
What was the rationale with heating the chemotherapeutic agents?
Heat can have multiple effects in terms of direct cytotoxicity to cancer cells, denaturation of their proteins, activation of heat shock proteins in not only cancer cells but also in stromal cells, immune infiltration and potentially immunogenic cell death. So it can incite an anti-tumor immune response. But also it has some pharmacokinetic properties that promote some synergism with certain chemotherapeutic agents. Now, not every chemotherapeutic agent synergizes with heat. And actually, one of the ongoing areas of research is normothermic perfusional intraperitoneal chemotherapy, HIPEC. But that's the rationale for heat. In 79, actually, the first patient that was treated with HIPEC was done by Spratt, and he used thiotepa, which is not a commonly used agent, but he heated it at pretty high temperature, 43 degrees, and he published the first result essentially of a effectively treated patient with HIPEC. Now, the Western countries forgot about HIPEC for a while, and the Japanese took the technology and developed it much further. Eventually, it circled back to the West a couple of decades later. It wasn't until Paul Sugarbaker developed his peritonectomy procedures that HIPEC took off in the West, really. And since then, multiple brilliant scientists and surgeons in Europe and the United States performed several trials and really nailed down the role of HIPEC in certain conditions.
That gets to the next question, is like currently where we stand now is what malignancies benefit from the use of HIPEC? There
are malignancies that we have, almost absolute proof, I would say, that benefit from HIPEC, CRS and HIPEC. CRS is cytoreduction, and HIPEC. And there's others that we have the sense that some patients benefit, but trials are somewhat controversial. So to understand what I'm trying to say is that we have to think of the biology of the tumor and think which patients and which malignancies have the right biology that can be targetable by this technology. So the way I think about it is that you are hoping to target a tumor that is locoregionally aggressive but hasn't spread outside the abdominal cavity. If you treat that by debulking and then treat microscopic disease with chemotherapy, then you have a good chance of long-term survival and long-term recurrence-free survival. If on the other hand you have a tumor that, even when it's very small, tends to disseminate systemically, and you are likely to have microscopic disease outside the abdomen, that's occult, and then it just flares, then you are not likely to offer the patient a benefit. And to that extent, cancers that are poorly differentiated, regardless of the primary, are not likely to respond well to CRS and HIPEC, because those cancer cells tend to exit the tumor very early. They undergo epithelial to mesenchymal transition. They find harbor in a dormant state in distant niches. And when the time is right and they have the favorable soil, then they just flare and develop into clinically evident metastasis. Whereas if you have an indolent tumor, like many appendiceal neoplasms, that is, let's say, probably the best example of where HIPEC is applied, those are indolent, slow growing, and they just spread in the abdomen. They never leave the abdomen, really, or they can, but they don't do that often. Then that's a good target. So I think Peritoneal Surface Oncology Group international recommendations are spot on, and they recommend that CRS HIPEC is used for the treatment of pseudomyxoma peritoneae and appendiceal neoplasms with peritoneal metastasis, and should be considered as also for selected patients with mesothelioma, for which is kind of the standard of care, and for patients with colorectal cancer with moderate to small volume peritoneal disease. Patients who have ovarian or advanced peritoneal metastasis from gastric cancer may benefit from this strategy, but we need to gain additional evidence through collaborative studies in experienced centers and so forth. And ongoing research is happening on neoadjuvant application of IP chemotherapy with systemic chemotherapy in many instances. And SOGI, the Peritoneal Surface Oncology Group International, recommends that we avoid administering CRS HIPEC in patients who are unlikely to undergo a complete or near complete cytoreduction or resection due to comorbidities, because these patients are unlikely to achieve a full recovery. We won't be able to penetrate the residual disease with the chemotherapy. And when you talk about that, what does survival benefit for these patients look like? Is that dependent on your amount of cytoreductive surgery that you can perform at the time of operation? Yeah, certainly. Predictors of survival obviously are primary tumor-related variables such as differentiation, grade, but also the burden of disease in the peritoneal cavity, as well as extra peritoneal metastasis, extra abdominal, I should say. So if someone has multiple lung mets or bony mets in addition to carcinomatosis, peritoneal carcinomatosis, then those patients are unlikely to benefit. Whereas if you have limited disease in the peritoneum, small nodules that can be effectively debulked, then you are much more likely to benefit from cytoreduction and HIPEC. And there's definitely more to come in the future by doing genomic analysis of the tumors and understanding better the molecular biology and their therapeutic vulnerabilities.
You mentioned this a little bit earlier, the chemotherapeutic agents that were available when this technique was evolving in the 70s. When we talk about the chemotherapeutic agents that we use now for this therapy, what are your primary agents that residents are going to encounter?
The most commonly used agent in the United States, I would say, is mitomycin C, and this is what we use in our institution in the patients that we treat with HIPEC. Mitomycin C is essentially an alkylating antibiotic drug that is derived from Streptomyces species, and it's a non-cell cycle specific agent. It has synergistic effects with hyperthermia, so that's why we use it for HIPEC, and it has a very favorable pharmacodynamic profile, meaning that it achieves very high concentrations and high area under the curve over time in the peritoneal cavity with minimal systemic dissemination. It can still happen and cause a side effect, but the ratios are very favorable, and the side effect profile is pretty acceptable, and we know how to manage it very well. And it's really the standard of care for appendiceal cancers, adenoma, peritoneal, and usually they go-to for colorectal cancer in the US in the centers that do that, but also for some other malignancies. There's also many FOLFOX-like regimens that are much preferred in Europe, and they have been studied. That's actually one of the areas of controversy in the recent trials, like the Prodigy 7 and so forth. And they're used for the same tumors that we use mitomycin C, but also doxorubicin cisplatin combo is used for ovarian cancer, for gastric and mesothelioma. I think to switch gears a little bit, because I think there's a little bit of mystique around how it's actually performed in the OR. Can you just talk a little bit about the technique after your cytoreductive portion of the case? Absolutely, yeah. Essentially, you approach the patient through an exploratory laparotomy. You assess the disease burden, and you can calculate indices like the peritoneal carcinomatosis index, which looks at essentially all regions of the abdomen and grades the disease burden. And if you decide that the patient is a candidate for debulking, that will likely lead to minimal macroscopic disease or no macroscopic disease, then you proceed with your debulking, the cytoreduction phase or CRS phase. Once that's completed, then you will set up your perfusion system. So we insert an inflow and an outflow cannula, which are connected to the perfusion apparatus. And we allow a dwelling of the chemotherapeutic agent at a set temperature. Usually we do it for 1.5 to 2 hours in the United States, and in our institution. In Europe, it's often done, and in some of the European studies, it's done for a much shorter duration. And again, that's one of the criticisms of some of the recent trials, and it's fueling a lot of debate and also enthusiasm for maybe more favorable results if the chemotherapy is done for a longer period of time with different combination of agents and so forth. And while we're doing this perfusion, we do, as Dr. Miner says, the shake and bake. So someone has to kind of agitate a little bit the abdomen so that chemotherapy gets distributed better. So the abdomen is closed at this point. You just have your access cannulas in the abdomen, and someone standing there for the duration of the dwell time. Yeah. So once the 1.5 to 2 hour dwell time is completed, then the abdomen is opened again, because during that temporary closure that's done in a kind of mass closure fashion, we don't use the anatomic closure that we often use. We just want a seal essentially, so that the chemotherapy can perfuse and dwell in the peritoneal cavity, and we ensure that hemostasis is obtained, and formal closure is performed once the cannulas are removed. This can be done also laparoscopically by experienced surgeons. There's advantages and disadvantages of that approach. Laparoscopic HIPEC has the advantage of reduced heat loss and increased tissue penetration due to higher intraabdominal pressure, which kind of pushes the chemotherapy into the tissues. But on the other hand, the distribution of the chemotherapeutic agents tends to be a little bit less homogeneous, likely because of the position of the cannula and the fact that you haven't mobilized the peritoneal surface the way you do when you do a formal cytoreduction and HIPEC. So this is another area of ongoing study, and in the same kind of thinking, people are studying delivering HIPEC with increased pressure in the peritoneal cavity if you do it open, to kind of try to match the effect you're achieving with laparoscopy.
What temperature are we achieving with our agents currently?
Usually it's around 41 to 42 degrees. It can be a little bit variable, and that can be set up on the perfusion apparatus. And another thing that I found interesting when reading about this recently is that the dosing of the chemotherapeutic agent is usually targeted to the body surface area, but actually there's ongoing research in novel perfusion apparatuses that can actually measure the concentration of the chemotherapeutic agent in real time in the perfusate, so that it can adjust it to that rather than just the size of the patient. And that way you're achieving a more focused target, essentially.
Great. I think that's a good time to go over some of the intraoperative considerations when you have these patients on the table. They're down there for a few hours at least between the cytoreductive portion and then the perfusate portion of the case. What is the discussion with the anesthesia, some of the physiologic changes that happens or that one can expect to go on while you're performing a HIPEC?
That's one of the most important things one has to consider when performing the HIPEC, actually. And you need to have an experienced team doing this. Not only the surgeon, the assistants, the perfusionist, the anesthesiologist, everyone in the room really should be on board and communicating clearly at all times. The reason for that is because obviously you have a long operative time. These can go up to 10-12 hours, as you mentioned, but you have significant physiologic changes during this operation, which are multifactorial really. You have an open abdomen for several hours, you're losing fluids, you have the stress of surgery, you are resecting tissues everywhere, you are doing peritonectomies, you are stripping the diaphragm, you're stripping the Gleason's capsules, you're ablating here and there, so you're generating a tremendous serous response in the patient, and that leads to capillary leakage, as we know, third spacing, but also many other physiologic changes. So you really have to be in close communication with the anesthesiologist, and you need to at times pause, ask them how is the patient doing, allow them to catch up with the appropriate fluids and so forth. Open abdomen and fluid losses can also lead to hypothermia, so when you're doing your procedure, it's good to have a heating device like a bear hugger that we commonly use on top of the patient. And on the other hand, the HIPEC, the heating part of the procedure, can cause hyperthermia. So you can deal with that by having a cooling blanket under the patient. So you need really good setup. You need to be prepared and be ahead of the game and anticipate the things that can go wrong. And as you know, temperature changes can affect metabolic function, immune function, coagulation. It's like when we have a trauma patient, really, and we are led to the little triad. You can have that magnified several times because you have so many other factors in play, including the chemotherapeutic agents and so forth. And that brings the question, how do you gauge your resuscitation, really? And the same things that apply to any critical care scenario apply here as well. So goal-directed therapy is probably the best way, even though it hasn't been studied that extensively in the setting of HIPEC. There is some evidence that it's probably the best way to resuscitate. Crystalloids are the most commonly used fluid for resuscitation, but to the discretion of the surgeon and the anesthesiologist, you can employ colloids like albumin. Albumin is actually favored by many experts in the field when you have a lot of ascites that you're draining, when you do significant debulkings, because you can have tremendous albumin losses. So you're doing point of care testing and you know that the albumin is low and you're resuscitating a lot, then you can also give some shots of albumin. That can be really helpful. You can employ devices that predict accurate bit-to-bit variation of hemodynamic parameters such as pulse pressure, stroke volume variation, and so forth, so it can guide your resuscitation so you don't fluid overload the patient. And you can also use point of care testing to measure hemoglobin, coagulation. TEG is pretty helpful, and it's paramount to correct the coagulopathy, really. Actually, a big part of the coagulopathy comes from hyperfibrinolysis, and some experts recommend using tranexamic acid as a way to counteract the hyperfibrinolysis that is associated with these long procedures. And the recommended dose is 1 gram every 8 hours of ongoing operation. And the last thing I wanted to mention here is that you can use cell saver, even though we are usually taught that cell saver is not applicable in cancer operations. You can do that if you expect significant blood loss. What you have to do in addition is to irradiate the saved red cells, and then you can administer them back to the patient.
Do you want to just speak quickly about some of the post-op management of these patients? Because our second and third year residents often manage these patients after a long day in the operating room, and they've gotten adequate resuscitation in the OR. How does that transition to them on the handoff, and what should they expect for the next 8 hours while they're managing these patients?
Yeah, absolutely. So essentially, once the operation is completed, the resuscitation continues. So the patient has to be in a monitored setting. Obviously, most of the times they'll end up in the surgical ICU. If it's a very limited resection and it's just a HIPEC, they can be monitored in the step-down unit. But usually they're intubated, and so they and maybe with a pressure requirement. So as I said, we need to continue aggressive resuscitation. We usually tailor our fluids administration to urine output and normal tension, essentially. But urine output is the easiest way to tailor it, and we're aiming for something like 1 ml per kilogram per hour for the first and second post-op day. That way you can counteract some of the side effects of the operation itself and ensure that you have good perfusion to prevent acute kidney injury and so forth. You want to check the patient's labs frequently, correct any anemia, correct coagulopathy, replete electrolytes. All these things can really impact the patient care. And it's important to note here that we usually see a drop in different cell lines and cytopenias that are a consequence of not only the SIRS response, but also the chemotherapeutic agents that are causing some bone marrow suppression. Mitomycin C doesn't have so much of a systemic effect, but other agents can cause much more profound bone marrow suppression, like platinum agents and so forth. So you have to anticipate that.
So what's the typical morbidity and mortality like for these patients?
This is traditional has been a very morbid operation. We're becoming better at that, but still studies quote a morbidity of 12 to up to 52%, and mortality can be up to 6% with in modern experience centers. So something that is very important in selecting your patients appropriately and being very aggressive with intraop and periop management overall.
Is this something that's correlated with malignancy type, or is this just all comers?
This is all comers. These are numbers for all comers, and certainly you can have some variation with specific malignancies, but these are the numbers for perioperative morbidity and mortality, predominantly because of perioperative events.
So I guess, that's a great overview there. If you were to look ahead for the next 5 to 10 years and the use of HIPEC, where do you think the future directions are for this therapy?
I think the future is very exciting, and I hope to get into that myself, to be honest. There's several trials that are in the works, meaning either being designed and now or are enrolling, and I think they're studying a few different things. Number one, studying new agents and different combinations with heat or no heat. So there have been a few recent trials, mostly in Europe, with negative results, seemingly negative results, but the time of the perfusion, the combination of chemotherapeutic agents, the patient selection is an area of controversy. So different experts in the field are coming together to see what can they change in those parameters to augment the effect of chemotherapy and target the patients better. That's one. The second thing is, which I think I mentioned earlier, neoadjuvant administration of IP chemotherapy as a means to prepare patients for surgery, downstage disease, and converting it to operative candidates potentially. And I think there's a lot of enthusiasm in the field of gastric cancer when it comes to that, especially in patients who have negative diagnostic laparoscopy pre-op in locally advanced gastric cancer, but they have positive peritoneal cytology. Those might be good candidates to give them IP chemotherapy and then restage them with a follow-up diagnostic laparoscopy. If they convert to negative cytology, then you proceed with your resection, assuming they haven't progressed somewhere else. I think in the future we're going to have also administration of targeted agents intraperitoneally, either alone or in conjunction with chemotherapy. I can see that happening, for example, in pancreatic cancer, where it's a very aggressive malignancy, but maybe you can avoid giving systemic targeted agents that can have off-target effects in some other organs. and give them just where the tumor is more likely to recur. And then the last thing that I think will come in the coming years with improvement in different technologies is employing molecular profiling of the tumors to help determine who will respond best to this kind of treatment, CRS and HIPEC, and potentially even identify actionable mutations or other therapeutic vulnerabilities, and then give the appropriate chemotherapy or targeted agents that can benefit these patients most.
Well, Constantinos, I just want to thank you. I think this has been a great overview, going over some of the definitions of HIPEC, its utilization, what to expect in the operating room, and the future directions for it. I'm going to hold you to coming back in 5 years and tell me where you're at and how much you've advanced the science. So I appreciate your time today.
I would love to. Thank you so much for the opportunity.
So thanks again to Dr. Constantinos Zambirinis for joining us today. I'm sure the residents will find this review extremely helpful as they prepare for a rotation on the surgical oncology service. Next week, we will continue our chief podcast project with Dr. Haley Leasley on the management of esophageal perforations. Stay tuned for that and other upcoming discussions on topics such as crushing compartment syndrome, carotid disease, and aortitis, to name a few. We will also be doing a special podcast takeover in a few weeks with some of our previous Brown Critical Care Fellows and faculty, so be on the lookout for that. Have a great week, and I'm looking forward to having you back with us in the next episode.